Thank you everyone for being here. I know you could be at the slots or the craps table, but I can guarantee you this is going to be more lucrative. So we're going to be talking about BPH updates, procedures with the fewest sexual side effects. I don't have any disclosures or anything to go through that are pertinent for this talk. But when patients come to us, this is really going to be clinically contextualized, because when people talk about what are the fewest sexual side effects for any sort of therapy, what does that mean? Is it what constitutes the actual fewest? Is it the least severe? Is it quantitative? Is it the shortest lived? And so we really, as providers, come up with these safety profiles of risk benefit. And in this case, the risk is going to be the sexual side effects. And a bigger thing that we have to go over today is, can we truly review all these in 10 minutes? So we're going to try and go over updates within the last year. So can we do it? Thanks, Kendrick. We'll see. So first we're going to start in going to the land of the myths. These are the minimally invasive surgical techniques. It's what we think of a lot of times when we're looking at techniques and surgeries that have fewer sexual side effects. And some of the new kids on the block that have been in the literature recently are these prosthetic stents. And they're not all stents. I think when we think prosthetic stents, there's some other things that our minds go to, but a lot of them are aimed at stenting open the prostate. The majority of these are composed of a nitinol core, and they have some sort of deployment. They vary different. They're temporary, some are permanent. And then there's also the paclitaxel-coated balloon, the Optilume, which is temporary, and it's removed after the stenting open of the prostate. And two of these are FDA approved in the United States, the I-10 and the Optilume. So that's the data that we will incorporate into our review here. And these are distinct from the urethral stents. I think a lot of us are familiar with these for taking these out now, but they used to be, they're permanent, they're made of nickel, and they're self-expanding, so they granulate into the urethral tissue. So it's something to be, lessons learned from prior experience. So let's start out with some of the data on the Optilume. This was results from the Pinnacle trial. It was Optilume versus sham treatment, 2-year follow-up for BPH. And the authors note that there's ongoing data, but they found sustained sexual function and improvements of the Qmax from almost 11 to 18 milliliters per second when they looked at their 2 cohorts. And then later on, we see this data presented more as a preservation of sexual function type of scenario in our JSM. And what the authors found when they looked at all of their men who are sexually active, they broke it into sham treatments versus those who actually got the stenting of the balloon. And they noted that there were similar background in their demographics, which is ideal. And then when we looked at the actual change in men with no erectile dysfunction at baseline 3 months, 6 months, and 12 months, you can see on the bottom left there's very little stratification. But as we move up into mild to moderate, and severe erectile dysfunction, we do see over the 12 months there is improvement in all of those domains. And also, if we look at the IIF and the MSHQ function bother scores, they stayed relatively preserved up to 12 months during this study, so it's very reassuring. Let's move on to updates in water vapor thermal therapy. Many of us know this as Resume. And so the authors of this study performed, or they compiled a bunch of data and performed a systemic review, meta-analysis on large glands, those being over 80 grams. And because we only have 10 minutes here, I can't get into a lot of the finer details of a lot of these studies. And I encourage you to go through and find the ones that are applicable to your clinical practice. What was reassuring is that the authors found that there was no decrease in change of the erectile function scores for these patients, despite up to a 50% change in gland size. Now, if we move that same sort of therapy into men with pre-existing erectile dysfunction, and then those who didn't, and stratify it with 4 years of real-world data, we get some of what the authors of this presented. And they noted that patients without pre-existing erectile dysfunction tend to maintain their sexual function over time, and that's in that higher green line that continues to have an upwards trajectory over the time course here. However, this was contrasted with men who had baseline ED, who maintained a temporary decrease, but then countered back and had improvement over the long term, as evidenced by that blue line with the dip, and then at 48 months had an ultimate improvement. And we do have comparative studies looking at the Resume therapy versus bipolar TERP. So we're looking at a gold standard and looking at the outcomes for BPH as a prospective randomized study. And what we looked at when looking at the erectile function scores and looking at between the Resume and the TERP perioperatively, both had levels of erectile dysfunction in the severe, moderate, and mild. Again, higher with the TERP group, But if we were to look and break that down by changes from the initial IIF in those two groups, you can see that in the water vapor therapy, the SHIM or the IIF scores actually improved while the TERP decreased. So some considerations there. Now we'll move on to ablative and endovascular therapies. And for the sake of this talk, I know there's more, and this is kind of a somewhat arbitrary classification here, but we're going to include PAE, or prostate artery embolization, the HOLEP, or holmium laser enucleation of the prostate, as well as aquablation. So let's start with that. This is a study from a single center, a large volume, 4-year follow-up of real-world data. And so we get one surgeon who's following along with his patients for some time. And they note that at the end of their follow-up, roughly 99% of their patients had preservation of ejaculatory function, and they had a decrease in use of alpha blockers from 67 to 15%. Interestingly, they had a slight increase in their use of 5-ARIs that they noted was patient and provider preference. And then as we move over to some of the other purported takeaways, the most common perioperative complication reported that was also consistent with the literature were UTIs, blood loss needing a transfusion, as well as surgical retreatment. Now, if we look at this comparative prospective randomized study or non-randomized study that compared aquablation with HOLEP, now we're getting some more of these therapies in a similar bucket compared. They had similar perioperative demographics, although the HOLEP group was slightly larger with their gland at 73 grams versus 55 with the aquablation. If we look at mean operative time, it was slightly longer with the aquablation, which was thought to be due to the setup and the conserved time taken for that. And if you had a much larger gland, you would expect to see that HOLEP time go up. 3 days post-operatively, the pain scores pretty much diminished to 0 in both groups. And then if you look at the outcomes in erectile function, it really stayed the same at about a year. And then the MSHQ, ejaculatory domain, was more improved in the aquablation group. So what about doing a deep dive into the HOLEP ejaculatory and erectile function outcomes? That's what the authors of this study did last year. And what we saw is that over the course of the year, there was a decrease following treatment in ejaculatory functions, mainly attributable to the decrease in frequency of ejaculation, the strength, and the quality of the fluid with the ejaculation. However, interestingly, that there was an increase in the an improvement, I should say, in the ejaculatory bother, and that score went up. So if we move over to the erectile function scores in this study, it suggested that patients don't experience a decline in erectile function, so again, reassuring. And interestingly, though patients experienced a decline in their ejaculatory function like we just saw, they didn't find this decline bothersome, so very reassuring. And in an effort to purport a new technology or new invasive, approach to holmium laser therapy and preserve erectile or ejaculatory function, the authors of this study proposed what's called a double N incision. And the way they did this is using the holmium laser at 1 o'clock on the anterior bladder neck, they would make an incision, and they go over to 11 o'clock as well and connect this in what was a U configuration and preserve that intervening tissue. Similarly, on the around the median lobe and around the veru, they would make an N incision, preserving the veru tissue, and then perform the rest of the HOLEP with those two areas left in situ. They performed a randomized prospective trial. The patients were either grouped into a conventional HOLEP, the veru-sparing N incision, or the double N incision. And what they found was that there was a statistical significant increase or improvement in conservation of anterior ejaculation in the double N group at 3 months, 6 months, and 12 months. And there was a decrease, semen reduction bother in that group as well. So let's move on to the last grouping in this group, the PAE, or prostate artery embolization. This is results from the PRO-STATE study. It's an international multi-center prospective trial looking at PAE for symptomatic BPH. We have 2-year outcome data that the authors looked at. They have roughly 400 patients that they were included, looking at scores in IPSS, SHIMS, the quality of life, prostate size, PVRs, and Qmax. And when we get the outcomes, what we have so far, looking at 24 months, The greatest improvement in the IPSS and the Qmax was at 3 months, along with a tapering off of those trends. The prostate gland size continued to decrease over that time, and interestingly, the PVR volume decreased by just about an ounce. And most of these studies, we're comparing procedure to procedure, kind of apple to apple, but in this particular study, the PEZ Advanced trial, we're looking at PAE versus a medication. They compared it to Duodart, which is a combination of tamsulosin and dutasteride. Patients either got the medication for 10 months and then had a 2-month washout and then got PAE, or they got the PAE right off the bat. And so we're going to see that outcome data, so expected that to come out soon. But we do see some of the initial adverse events coming out. And the Duodart group, as you would expect, has decreases in their ejaculation, their erectile dysfunction scores. And if we look at the PAE group, there's increased urinary frequency, painful urination, pain in the rectum, penile pain, and blood in the urine and semen. So the group out of Sweden here performed a non-inferiority trial looking at PAE versus a TERP. So now going back to our gold standard, giving us 5-year outcomes data in this randomized trial. And even though you can see here the PAE group did start out with a higher IEF, the TERP and the PAE groups continued to have the same sort of trend over the course of 2 years and then up to 5 years as well. Although if we look at functional outcomes with the Qmax as well as PVRs, those did favor the TERP. So in conclusion, we have newer BPH therapies that have varied effects on sexual function, but we have a conventional therapy trying to compete for relativity. And what is this? Oh, the resectoscope. We can't forget about that. So in researching for this study and going back over the course of the published data over the last year and a half, came across a comparison of TERP, conventional TERP versus a very sparing TERP, so kind of like what we see with that AND incision for that HOLUP study. And it's from the Urology Journal, which is not to be confused with the Journal of Urology, which is the official journal of the American Urologic Association, which I made the mistake. And you look a little bit closer and you see it's the actual official journal of the Iranian Urology Association. And then you look a little bit closer and you start going down a research rabbit hole because you see on the representative journal entry, there's a paper on the efficacy of sexual intercourse and masturbation with a systematic review for the expulsion of distal ureteral stones. And so it's a sexual medicine conference, so we said, hey, it's interesting. And to save you a click or looking at it, at 2 weeks, it's favorable, 4 weeks, it's reasonable, so yes. Now, but getting back to a TERP, so we're again conventional TERP versus the very sparing TERP. As you might expect, there was preserved ejaculatory function in the very sparing TERP, and then the retrograde ejaculation instances were higher in the conventional TERP. This was reinforced by a prospective study done the same year, ejaculatory presenting TERP versus a conventional TERP. And when we see the outcomes, what they reported from a sexual standpoint was there was improvement in desire scores in different domains. PSA remained the same, and erectile function domain roughly remained the same. So bringing it all together, last study here, so thank you for your attention and being here for this. It's a lot of data. But this is from Sexual Med Reviews. It was a meta-analysis of randomized controlled trials for ejaculatory-sparing transurethral prostatectomies. And the authors explored studies that included the terms vaporization, enucleation, or resection. And looking at the forest plots, again, we see reassuring evidence that the IIF remains the same. Similarly, retrograde ejaculation favors ejaculatory-sparing techniques for these surgeries. And the IPSS, interestingly, favors these techniques as well. So now, in true conclusion, new BPH therapies have varied effects on sexual function. Longer-term data on targeted therapies support the benefits of ejaculatory-sparing techniques, and sexual outcomes data is forthcoming with novel therapies. Thank you very much.